A love of mine, and we've got a lineup of 4 great speakers. If you're going by the booklet, poor Saf has been dropped off the end, so please stay. There are not 3, there are 4. And so first of all, a little bit of housekeeping. We'd like to thank our sponsors for supporting this session and also the conference. And just the usual things, please put your phones on silence, etc. So without further ado, I'd like to introduce the session of paediatric opium dreaming. If you think we're actually talking a lot about opiates, I don't think we are. It's mainly sedation. Were you opiate dreaming when you thought up of this topic? Okay. So first of all, I'd like to introduce Dr. Simon Erickson, who's discussing optimising sedation, inconsistency, dogma and confusion. Simon's a lovely colleague of ours from the New Perth Children's Hospital and is a staff specialist in intensive care. He trained in paediatric intensive care at Princess Margaret Westmead Children's Hospital and the Sick Children's Hospital in Toronto, and spent some adult intensive care time in Sir Charles Gardner in WA. Thanks very much, Simon.
Thanks, Debbie, and thanks for asking me to speak. I've been asked to speak about optimising paediatric sedation, inconsistencies, dogma and confusion, or as Donald Rumsfeld likes to call them, unknown unknowns. These are the things we don't know that we don't know, in one of the most memorable quotes of the 20th century. So I'm going to touch on a few issues, and I know my esteemed speakers following me at delving into these in more depth, so I'll skip over those bits. But I'm going to talk about sedation in specific groups, so looking at age and disability, different diagnostic groups, how that affects sedation, talk a little bit about some specific drug toxicities, and then touch on delirium, tolerance withdrawal, post-traumatic stress disease, which is a fascinating area, and effects on the developing brain, and also this conundrum of depth of sedation. How deeply should we sedate children? How deeply are they sedated? And what are the pros and cons of each of those approaches? So sedation in critically ill children, it's ubiquitous. It provides safety for intubated children, helps with ventilator synchrony, provides sedation amnesia, importantly, for stressful or painful circumstances, and avoids some of the consequences of agitation and wakefulness, such as raised ICP, pulmonary hypertension, etc. And adequate management of pain and anxiety may reduce the incidence of post-traumatic stress, although there's not really any evidence to support that. But there's little evidence to support the guidelines that we use. And most drugs that we use in children are not FDA or TGA approved for that use. Organ failure in critically ill children really strongly affects clearance, and hence adverse effects are quite prominent, particularly negative CVS effects. Tolerance and withdrawal are very common. We don't know about the long-term cognitive effects, and delirium has been essentially an unknown quality, and we don't really know its association with long-term outcomes. There are many factors. Look how happy that baby is. There are many factors impacting sedation. We've got it in children. We have a wide-ranging cognitive levels due to different ages, wide-ranging levels due to underlying conditions, and so assessment is pretty difficult. And obviously, there's variable psychological adjustments to stress, agitation, and pain based on children that have chronic illness, that are hospitalised, cultural influences, and also the presence of families around children. Some idiosyncratic drug responses, which I'll talk about, which makes things difficult. And there's always the big safety concerns. Everyone's paranoid about accidental extubation and line removal, particularly in children, where these are probably at a higher risk than in older children and adults. So how do we optimise sedation? Well, there's been a little bit of work in this area. Martha Curley's RESTORE study was a large cluster randomised trial, I think of about 3,000 children. And they had an intervention group which had targeted sedation, arousal assessments, extubation readiness tests, and strict sedation titration. That was compared to a standard sedation or unspecified group, and that was done in different hospitals. And while it provided an amazing amount of data, it actually didn't show any difference or any advantage of this protocolized sedation. There's a study out 2014 which suggested that sedation guidelines may reduce PICU length of stay. And there was a nice paper recently from sort of a Dutch Royal Children's Hospital combined paper just looking at targeted sedation post-cardiopulmonary bypass. I'll just talk a bit about that study later. The adult data seems to suggest that, well, there's a move for this safe light sedation based on Prodex and MIDEX trials, which were big trials of about 500 adults, comparing dexmedetomidine to other sedatives, showing that ventilation was reduced. And the SPICE trial has been completed. Data's almost done, and that's going to be presented soon. That's a 4,000 patient study. And Jean-Louis Vincent's got this e-cash concept, which is really nice, actually. It sort of just looks at all the different aspects of sedation and really looking at, firstly, getting the analgesia right, trying not to over-sedate patients, and then dealing with this humane sort of family-centred approach, which I'd say we don't do very well at the moment, although I'm seeing some move towards it. But things like sleep promotion, day-night balance, modification of environment, that sort of thing, which are all really important as well. About 70% of critical care physicians used assessment in targets in a big survey from the US recently, and we used the 3 scoring systems mainly used, the State Behavioural Scale, Comfort B, which are both used in Australia and New Zealand, and the SBS is derived from the RAS, which is still used, and there's a bit of a move to go back to that. But it's very difficult to tell pain and agitation apart, and things like thirst, hunger, fear, delirium all can cloud that picture and make it very difficult to assess. And getting the balance is really difficult. And this is a nice review from the Dutch group looking at a number of studies here, and you can see over on the right the high prominence of over-sedation in most of these studies. So it is a bit of a problem. Oops. So how does age influence sedation requirements? Well, we have such a wide, varied age in paediatric intensive care, from tiny babies to adolescents and even older at sometimes. And we know that sedation and analgesic dose requirements are dependent on clearance, and clearance is the one thing that varies a lot with age. So neonates have significantly reduced narcotic clearance and significantly reduced benzodiazepine clearance, which I wasn't really that aware of. But the elimination half-life in a baby of midazolam is about 4 to 6 hours, and in a preterm baby about 22 hours. So that's why we get into trouble sedating these babies and not being able to wake them up. Alpha-2 agonists have a peak clearance between 1 and 5 years, and the adverse effect profile of sedatives may differ with age as well. So there seems to be an increased risk of Propofol infusion syndrome, for example, in younger babies. Bradycardia with dexmedetomidine is probably more prominent in smaller babies. And you've probably all heard the term, oh, this patient's got Down syndrome, we're never going to be able to sedate them, they're going to be crazy, or this patient's a redhead. There's no evidence of studies for redheads, but there has been a little bit of work on trisomy 21, mainly from the Rotterdam group, and first study was comparing sedative analgesic requirements in children post cardiopulmonary bypass, and it actually showed there was absolutely no difference between children with Down syndrome and non-Down syndrome with regard to sedation scores, sedation requirements, and analgesia requirements. And the second study, again, looked at anaesthesia requirements and post-op analgesia again in surgical neonates and showed there was no difference. So we have a few misconceptions that about patients that are probably not necessarily true. There's been a little bit of work. There's been a lot of work in cardiac surgery and sedation, mostly case series presentations. But this is a nice one from was published 2 years ago, just looking at this sort of. They compared 2 different sort of eras and had this targeted sedation just using narcotics and then going to clonidine. You can see the algorithm there, and then going to midazolam as a third line. And they showed using that sort of approach that you had only about, I think about 20% of the patients needed sedation in addition to opiates in the first 12 hours, and only about half the patients over their first 48 hours actually needed a sedative when they adequately managed the analgesia first. And there was no difference in outcomes or cardiovascular instability between those groups. There's been several case series looking at alpha-2 agonists in cardiac surgery, and so there's been a little bit of work in different groups, but one of the really interesting papers I looked at was this concept that if you have previous surgery, it leads to increased pain sensitivity and analgesic requirements after surgery. And this was a study looking at babies that had previous surgery, they had repeat surgery, and as compared to groups that hadn't had previous surgery, there was a huge increase in their pain that they got, pain scores and analgesia requirements, particularly if their surgery was in the same dermatome as they had previously. So there seems to be some sort of adjustment or learning of pain. With intellectual disability, CP patients, which are a lot of our patients, that unfortunately these kids don't get included in studies, so we don't know what their requirements are, whether they differ. They have so many drug interactions that it can really make things difficult. So just wanted to touch on a few specific drugs. Obviously, Propofol infusion syndrome is a big concern and was reported in 1992 for the first time. In fact, if you look at the literature now, most of the reports are in sort of elderly patients. I suppose because we've limited the use a little bit in paediatrics, but it seems to be due to impairment of mitochondrial beta oxidation of fatty acids. You get build-up of fatty acids and blockade of beta receptors and calcium channel blockers, and that gives that syndrome, which has a mortality of probably around 50% or greater. And it's associated with prolonged use, always more than 48 hours, high doses, 4 to 5 mg per kg per hour, younger age, and a few probably different groups. But there's not really treatment options, unfortunately. And even though there's several large series showing that with using Propofol showing that it's safe, it's still a big concern. And most units, reduce the length and dose of Propofol that can be used in children, particularly young children. Doesn't really appear to be any warning signs either that are reliable to prevent before it becomes severe. We're going to talk about dexmedetomidine in another talk, and we've talked about that already this conference, but this is becoming very widely used and useful drug. It has sedative, anxiolytic, sympatholytic, and analgesic properties. So it's ideal for post-operative sedation, not TGA approved for use in children. It has a elimination half-life of about 2 hours, so it's quite easy to manage. And overall, the adverse effects are pretty low, about 3.6%, mainly bradycardia, and it's mainly very manageable, bradycardia, even though there has been some severe adverse effects described. One of the advantages, it appears that these drugs cause less neurodegenerative effects, at least in animal studies that have been done so far, although it has to be said, there has been some studies showing that it can cause some adverse effects in these animal studies, but it appears to be relatively neuroprotective. Ketamine is a PCP analog, NMDA receptor antagonist, sort of gone out of favour. It has a lot of advantages. It stimulates the limbic system but depresses the cerebral cortex, hence the term dissociative anaesthetic. It's a very good analgesic. It's very good anaesthetic, has sympathomimetic effects, so is quite good from a cardiovascular point of view. But the main problem's been this emergence phenomena, which is seen also quite small doses too, up to 40%, characterised by euphoria, hallucinations, very distressing for families and children, and isn't really tempered by addition of midazolam. Midazolam's had a pretty bad rap recently, mostly because of some animal studies and concerns about long-term effects, but it is a good sedative. It's the most commonly used sedative in PICU still, and it has good antegrade amnestic properties, which are obviously can have some advantage in children undergoing procedures. It has very prolonged clearance, particularly in neonates and children with multi-organ failure and SIRS, which is a lot of the children that we look after, obviously, in PICU. And the long-term cognitive effects has been associated with PTSD and delusional memories, and also these animal studies, which I'll briefly touch on, but I think Cedric is going to talk about a lot in his talk. Delirium is another big unknown area. There's more knowledge now about it, but it's got 4 cardinal clinical features: acute change or fluctuation of mental state, inattention, altered level of consciousness, and disorganized thinking. And very common in adult ICU and clearly associated with impaired long-term cognitive function in adults. In children, not so clear, evidence isn't so good, but it's obviously very distressing for families. It causes a risk of injury and extubation, and potentially has sequelae that we don't really know about yet. And I just read a really beautiful review on delirium. And there's a point prevalence study published in 2017 showing maybe 25% incidence in paediatric ICU, and that hypoactive delirium was actually the most common form seen. Its incidence is related to younger age, pre-existing behavioural neurocognitive problems in children, and then severity of illness. So, big spike in patients with high PIM scores, long mechanical ventilation, ECMO, long length of stay, and probably it has sort of been associated with all sedatives. Midazolam's been the one that people talk about, but has been shown to be associated with all those sedatives there. And we don't really know what the sequelae are yet. There's just not enough evidence out there, but it definitely increases health costs. It's been shown before, so big concern. The other thing that I find really interesting is this whole concept of post-traumatic stress disorder, which has only really sort of come about, in the literature and talked about fairly recently. We know that children experience fear in ICU. Gillian Colville showed this incidence of 28% of PTSD post-PICU with delusional memories and PTSD seem to be associated with midazolam more than the other drugs. And we know that it may persist in children up to 12 months, so it's a big concern for us. The adverse psychological sequelae in PTSD was shown to be associated with a number of invasive procedures, which is a bit of a concern. And it's also quite common in parents as well. So, and child and parent pairs, maybe about 40% suffer from PTSD, and it can persist in the Colville and Pierce study, persisted for up to 12 months, so it's a big concern. I won't talk too much on drugs in the developing brain, but you've probably all seen these animal studies from Young, British Journal of Anaesthesia, and Economedu, looking at the stain for apoptosis and showing that ketamine and midazolam is associated with this. But there is still some good evidence. The GAS study, which was published a couple of years ago, showed that there was no long-term effects, or at least at 2 years, from general anaesthesias as opposed to local anaesthesia. There's been some long-term follow-ups of children that have neonates having morphine up to 9 years, showing no adverse sequelae. So I think this area is pretty unclear, and if you look at some of these studies, they're quite hard to interpret. Look at the dose of ketamine used in this study. 7 doses of 20 milligrams per kilogram. So how we relate that to our current use of these drugs, we know we've been using, for instance, midazolam's been used for decades. So we really need to weigh up that and weigh up the risks and benefits of using these drugs. Those effects seem to be dose-related. You can see these are from animal studies, and the pink shows some neurodegeneration. But the graph down the bottom there shows all the studies that have looked at positive and negative effects of drugs on the developing brain in animal studies. And there's quite a balance of studies that have shown adverse effects, but a lot of studies that haven't shown any adverse effects in these studies. So I think it's a bit of a grey area. Last thing I wanted to talk about is this conundrum of deep versus light sedation, and this sort of came about in first with the adult literature, Prodex and Midex studies. These were, I think, 500 patient studies looking at comparing deep sedation to light sedation with dexmedetomidine. It's a balance, isn't it? Like the risk of accidental extubation or loss of lines is actually a real risk. This is from Martha's Restore study, just the baseline data, but showing sort of out of 300 patients, there was loss of an ET, accidental extubation, in 20 subjects and loss of an invasive line in 20 subjects. So that's quite significant. It's about 7% of patients, and it can be catastrophic. It's usually related to agitation, lack of sedation, self-movement. There's been quite a lot of work on this, and it's got a high risk of reintubation. Those patients that self-extubate at risk of harm, and they at risk of prolonged ICU length of stay. And I'm sure you've all experienced a terrifying moment when the patient that no one's been able to intubate self-extubates on the ward. Well, I have a couple of times, and it's not good. So the other thing, last thing, I just presented the baby spice data on Thursday from the pilot study, and this is, with this study, we looked at a targeted sedation versus standard sedation. using dexmedetomidine, aiming for safe light sedation, so an SBS score of -1 to +1, so calm but responsive patient. And really, our aim was to see whether using dexmedetomidine as a primary sedative was safe. You can see the algorithm there. So we used the dex, narcotics, other sedatives, and then midazolam last, as compared to the standard sedation group, which generally used midazolam as a first line. And we showed in that study that you were more able to achieve light sedation using dexmedetomidine, 75% versus 63% in the first 48 hours. There was no difference in duration of ventilation or patient-centered outcomes in that study, but it showed that it provided safe light sedation faster, it was more effective. There was quite a small use of breakthrough midazolam in that group, only 14% of patient days, and it had a very favourable adverse effect profile. So it's just something to think about, something to back up, giving us some more armamentarium in sedation. So just in conclusion, most clinicians believe that titration against sedation targets is important, but the evidence supporting protocolized sedation is conflicting. The ideal sedative doesn't exist, but options are probably improving. Age and chronic illness may affect sedation requirements, so it's always something to think of. But variable efficacy and metabolism is a big concern in critically ill children. Tolerance, withdrawal, delirium are very common, but their effect on long-term sequelae in children is uncertain. And we know that PTSD is probably common as well, but the contribution of sedation to that isn't clear either. And long-term effects of sedatives on the developing brain are still unknown, so we're waiting to see whether that evidence is going to come through and be verified. Thank you.
Thanks, Simon. Does anyone have a question for Simon? No, I do. Simon, if you could wear your unicorn outfit.
Yeah. I've got it here.
Okay. Everyone imagine that. And you had unlimited money and resources. You know, this last slide you put up here kind of paints a system of we're not quite sure where we're going. We're trying to find the right answer and we're not really achieving it, and we're kind of going around in circles, and we're talking about a really heterogeneous group in PICU and possible lots of risk factors, and none of the drugs are approved by the TGA for use in children. If you could design the ideal trial moving forward, or what would it look like to you?
Yeah, it's difficult because sedation's really evolved, I suppose, in the last few years. So with the use of dexmedetomidine, the sort of avoidance of midazolam. So at the time we did the Baby Spice study, it wasn't too hard to get equipoise and have a standard sedation group that was pretty homogenous as far as the sedatives were used in that. It'd be a bit more difficult now, but probably something like a cluster randomised trial or a cluster trial comparing what different units do would be one option, because we've seen for instance, Royal Children's with that Kleiber study, that sort of approach. We've got the midazolam still pretty widely used by a lot of units, and then there's a dexmedetomidine group. So something comparing all those. I think that this sort of humane care, non-pharmacological adjuncts is something that we're really behind with. And in fact, I can even see the adult groups doing RCTs with melatonin and earplugs and all this sort of stuff. And that's something we should have been way ahead of the game there. But I think that's something else that is going to aid in the way we manage things. But doing a trial, standard RCT would probably be quite difficult, I think.
No other questions?
Yeah. Well, we use a lot of chloral hydrate actually in Perth. I'm not sure if everyone else does, and I know some of the units use a lot of oral Valergan, and we're always trying to transition to oral with the longer term patients. So I think it's part of the armamentarium, and it works just as well. Bioavailability is pretty good for most of the oral sedatives. So yeah.
And do you start it off pretty quickly in your unit? Because we try and get it up and running within about 12 hours if we can, the minute they start feeding. Yeah,
well, we always start chloral hydrate straight away as soon as we have a sedated patient, but we'd use all the other ones intravenously and then sort of grade them over, I suppose, after 4 or 5 days. But they work pretty well orally, actually.
Thanks very much, Simon.
Okay.